Bismillahirrahmanirrahim. This is a lecture talking about a very important subject in surgical practice, which is the surgical site infection. We will talk about the definition. We will focus on the surgical site infection and wound classifications. We'll talk about some of the care bundles we take to prevent bring down the rate of surgical site infections and the use of antibiotics in surgical practice. So the hospital-acquired infection, nosocomial infections, are the infections uh, happening to patient after hospitalization, like infections occurring more than 48 hours after hospital admission, the patient like undergoing surgery and having infections of different types after their hospitalization. So they are different from what we call the community acquired infections. So what's the importance of surgical site of the hospital acquired infections, its effect on the morbidity mortality of the patients, the extended stay, the unnecessary or the added cost, the added investigations, burden on the health system, delayed return to work. كل هذه important factors that will affect the outcome. Among the hospital-acquired infections, we will focus, as we said, on the surgical site infections. There are other hospital-acquired infections like the urinary tract infections, the respiratory infections, the catheter-related infections, other IV access infections. كل هذه types of hospital-acquired infections. لكن احنا بيهمنا surgical site infections in impact. It's actually a true important problem, adding to the cost, affecting morbidity, mortality, affecting the hospital stay, added زي ما حكينا excess need for doing investigations, workup, and occupation and using the resources for the health system. The length of hospital stay is prolonged, the cost is added, augmented if there is this problem, which is the surgical site infection. So by controlling factors, by decreasing rates, we improve these factors. Classifying the surgical site infection, we can classify it according to the anatomy. Into superficial incisional surgical site infections. You would remember from the anatomy there is the skin, subcutaneous tissue, and هذه بنسميها superficial layer, where superficial incisional site surgical site infections occur. These occur within 30 days after the operation, as we said. Deep incisional surgical site infection happen below the level of the fascia of the muscle. I mean, below the skin subcutaneous fat, there is the muscle fascia and the underlying muscles. If the infection extends there, this is called deep incisional SSI or surgical site infection. If it extends beyond this, then we go the organ space. I mean, like the peritoneal cavity, the pleural cavity, or I mean deep to the muscles like the neck مثلا بنسميها organ space. If there is infection extending there, بنسميها organ space surgical site infections. طبعا بيدخل بالتعريف هنا if there is an implant إنه الانفكشن is still considered surgical site infection up to 1 year. After this, it's not considered infection. Now, classifying wounds according to type of wounds. This is very important classification. to determine rate risk of infection and the management. بالتالي اللي بيحدد خلينا نقول الاوتكم تاع these surgeries regarding rate of infection. So we classified wounds in surgery into uh, first clean wound, and then clean contaminated or dirty infected. طبعا هذه كلها degrees حسب ال degrees of contamination. بمعنى if there is no break in the aseptic technique, everything is perfectly done without contamination, either endogenous or exogenous, we consider it clean, and then go up to the degree of contamination. We'll talk about some factors in defining the type of classification. طبعا هذا زي ما حكينا بيحسب وبيعطينا idea عن الريت of infections والmanagement. بمعنى انه in clean surgery we don't need to give any prophylactic antibiotics except in special cases like in patients who have a low immunity, like patients having or receiving chemotherapy مثلا, or they have immune compromised status due to drugs or diseases. كمان whenever you have like cases where if the infection happens, the outcome will be a disaster. For example, if you're doing mediastinal surgery, if there is an infection, mediastinitis is a very bad outcome. I mean, it's a life-threatening condition. So we can give antibiotics. Otherwise, in clean surgery, the rule is not to give antibiotics, prophylactic dose. In clean contaminated and contaminated surgery, we do give prophylactic antibiotics. In dirty surgery, we give therapeutic antibiotics because it's not enough to give prophylactic doses. As we said, factors telling this is clean or clean contaminated, there is operation, there is no inflammation, you are not entering any of the hollow viscous like respiratory, like GI tract, urinary tract, genitourinary tracts. There is no break in the aseptic techniques, there is no drains, there is no foreign bodies, it's an elective surgery, everything is okay, the aseptic technique in the operating room is not violated by any mean. This is clean. Then if you go one step with minor break in the aseptic technique, where you're entering a prepared or clean viscous or tract, then this is called clean contaminated. If you go further contaminated step, like having a gross contamination or unprepared viscous opened, or there is major break in the aseptic technique, this is contaminated. If you are operating on a dirty surgery, like gross pillage viscous, perforated viscous, like feculent peritonitis, or there is pus and abscess, intraperitoneal abscess مثلا, or a major break, or there is devitalized, there is dead necrotic tissue, كل هذه نسميها dirty surgery. زي ما حكينا هذه predicts outcome risk of infection that can go up sometimes 30, 40, or even 50% case of dirty infected cases, while it's around 1% in the clean surgery. The risk factors predicting the surgical site infections can be classified into operation factors and other factors. We'll talk about them. The operation factors, like I said, duration of scrubbing, maintaining body temperature, skin, antisepsis, preoperative shaving, duration of operation, antimicrobial, operating room, foreign materials, surgical drains, techniques, and one is the patient characteristic. So either it's related to the operation and the external factors or to the patient himself. Patient himself, like the age, the comorbidities, like diabetes, like nicotine use, I mean smoking, steroid use, malnutrition, obesity. These are important factors. Prolonged hospital stay before surgery, um, preparative transfusion, this is controversial, and other factors affecting the immune status. Now, the risk stratification, there are three independent variables associated with surgical site infection. Very important to know these three factors اللي هم degree of contamination, the ASA score, and the length of surgery. كل ما زاد هذه الفاكتورز towards contamination or towards خلينا نقول severity بيزيد the risk of infection. ASA more than 2, contaminated surgery, and length of operation more than 75th percentile of the specific operation being performed, then there's significant increase on the risk of having an infection. Antibiotics, so you have a second choice in these patients who are sensitive for like the penicillins or cephalosporins. There are other types of antibiotics that can be used in these patients. Very important, each institution in each area, each kind of surgery, studies should be run all the time to study pathogens for this specific institution and to dictate the type of antibiotics that should be given there. And by always antibiotics is something to help you decrease, but by itself does not prevent infection. We should stick always to the aseptic rules, technique, and other factors decreasing the risk of infection. Okay, so what are the strategies? We will talk about core strategies and supplemental strategies. These are suggested strategies either with high level of evidence or some scientific but not high level of evidence demonstrated. It should be used or advised to be used in surgical practice to decrease the risk of surgical. Talking about the core with high level of evidence, there is the administration of antimicrobial prophylaxis, as we said, 1 hour prior to incision, except for the vancomycin fluoroquinolones for 2 hours. And as we said, against specific type pathogen, there are guidelines for every institution according to type surgery, type of pathogen, resistance, and other factors we said. It's always recommended to treat and eliminate any other infections before doing surgery. For example, if you want to schedule a patient for like prosthetic valve for the heart or for like a hip replacement, orthopedic procedure, or whenever you want to do surgery on the, for example, aortic valve replacement, and you decided to screen your patient with he's having symptomatic, and you did an urine analysis, found him to have a urinary tract infection. So it's always recommended to treat this infection and any remote kind of infections eliminated before doing surgery. And this is talking about elective surgery. Preparation before surgery is always recommended not to use razors to shave hair in the site of surgery. It's always, if necessary, removed by clipping or depilatory agents. Skin preparation and is done by the proper antiseptic agents and technique for the skin preparation. So it's recommended shaving with proper agents and use antiseptic solutions. Now, normothermia is a very important thing, immediate postoperative normothermia. Normothermia is a very important thing in patients because in the OR, the patient will be exposed, is susceptible for hypothermia, especially because we maintain the temperature of the OR relatively low to decrease the rate of infections. So we don't want the patient to develop hypothermia. So we use measures like the heating mattress, the bear hugger, using warm fluids to maintain the body temperature, because no hypothermia is associated with uh, increased risk of infection, increased risk of heart attacks, and increased risk of coagulopathies. The OR traffic is an important role. OR should be designed in a controlled manner. The traffic of personnel, traffic of air, temperature, controlled number of personnel inside the OR. كل هذه factors should be controlled um, to decrease the risk of. طبعا post-operative measures. Now we're done with the surgery. What to do? First of all, the incision should be covered at least 24-48 hours. You know, it's time for having epithelialization, for the incision to be completely covered with epithelial tissue. Needs around 24-48 hours. So the incision should be covered. The blood sugar control in diabetic patient is very important issue. This has been a subject for research in the last decades, and we started to think first that we should be very strictly controlling sugar in a normal, like having patients on insulin pumps, IV insulin to control sugar below 140 or 126 or 110. But nowadays, a recommendation to decrease the risk of complications, postoperative complications, without having the risk of having hypoglycemia with the aggressive insulin therapy. The recommendation is to maintain blood sugar below 200. This significantly decreases the risk of possible complication, and among them, what we are talking about is the surgical site infections. Nasal screening هذه supplemental cause and decolonize the staph aureus. هذه يعني واحدة من recommendation. Screen preparative blood sugar levels and maintain tight sugar control. كان زي ما حكينا tight sugar control اللي what we said إنه to maintain blood sugar tightly below 140 or 126. هذا nowadays not recommended anymore. The recommended measures is to have it below 2. Feedback of surgeon specific infection rate. We'll talk about it in a minute. This is a very important factor because surgeon specific infection rates can vary between different surgeons according to different factors, and we will talk about it. Now, pathogen source, always keep in mind, whenever you have clean surgery, most likely the pathogen will be exogenous. If you are talking about contamination on dirty surgery, the pathogen will be endogenous. So whenever you go like towards the dirty, it's endogenous. If it's clean, most likely this is exogenous. Exogenous from where? From the surgical personnel, from the practicing the aseptic technique, physical environment, ventilation, tools, whatever. Okay, what are the microbiology? What are the pathogens for surgical site infection? There are a number of pathogens, most commonly causing the surgical site infection. If you want to remember one name, it's always the Staph aureus. And fortunately, it's not the methicillin resistant is the most common. The most common is the methicillin sensitive Staph aureus. But there is a burden, there is a big problem in methicillin resistant Staph. Uh, you can see the volume of the problem. It's rising in numbers, and the impact of the outcome is significant because it's increased cost, increased length of stay, increased added cost in terms of investigations and needs for ICU care and increased morbidity and mortality to work. This trial talked about the importance of timing of surgical antimicrobial prophylaxis in surgery. The antibiotics were given in different times, and as you see, the best timing, best outcome came with the timing that's less than 2 hours. We usually say like 1 hour before surgery or before. Um, Now, this is what we are going to talk about in surgical technique. As we said, risk of infection can vary from surgeon to surgeon. This is due to technique. Uh, First of all, there are different types of surgery that can be, or access for surgery can be used to perform the same procedure. You know, there is the minimally invasive surgery, there is the open classical surgery. Now, there's been proving that in many types of surgeries, like the colon surgery, the gallbladder surgery, appendix, etc., many types of surgery, if you go for minimally invasive surgery, the rate of infection is uh, the rate of infection significantly goes down. So this is one factor. In surgical technique, the following specific principles of surgery, like removing necrotic or devitalized tissue, is very important to decrease the risk of infection, because if you leave the tissue there, this is a good media for bacterial overgrowth. While if there is well vascularized, well perfused tissue, the blood will fight against infection. Maintaining effective hemostasis. If you are performing surgery and the hemostasis is not properly secured, and then there is the risk of bleeding, there is the risk of developing hematomas, which is a collection of blood inside of surgery, or um, uh, after surgery, the blood, this will be a perfect media for bacterial overgrowth and bacteria developing surgical site infection. Again, gently handling tissues to prevent risk of bleeding or risk of devitalizing this tissue increases or decreases the risk of infection. Dead spaces should be eradicated. Why? Because if you leave dead spaces, this will be filled with fluids, either blood or serum, seroma or hematoma, and again, this is a good media for surgical site infection, for bacterial overgrowth. Very important always to pay attention not to injure viscous organs, because this will allow contamination, spillage of contents and contamination, and this will invite infection. Using of sutures and drains properly in surgery is a very important factor, because if you don't need a drain, nowadays we don't use a drain unless it is indicated, because it is associated with this risk of inviting infection. Sutures can, if not properly used, can increase the risk of infection. For example, if you are using permanent sutures that are not absorbed by the body, with a degree of contamination, or while around the viscous organs, with going with piercing or going into the viscous organs, this will invite infection and complicate surgery. We said that parameters in the operating room should be controlled. Temperature, the ventilation, the humidity, movements of air, personnel, everything is controlled. So a lot of parameters, a lot of factors to be controlled. This makes things adjustable, but sometimes difficult to be controlled. I mean, there's a challenging thing to bring down the infection rate to zero. It's never zero. You can work on many factors to control infection, to decrease the rate, but sometimes very important, because lack of the standardized methods for post-discharge surveillance. I mean, um, you may have infections that are not detected. Maybe the numbers are underestimating or overestimating the reality. And again, nowadays we are trying to do what's called the fast track or the day surgery, outpatient surgeries, decreased hospital stay. Sometimes this makes following up patients, surveillance, detecting real numbers difficult. The bacterial resistance is another problem, increasing the difficulty for controlling the surgical site infection. Thank you.